Merci, thank you very much. Merci beaucoup aux organisatrices de GenderNet pour cette réunion aujourd'hui. I will continue in French, but it's really a pleasure. We had a real nice time when we were in Paris, and I was just telling Chloe that she tried to beat the view, but it's not so bad, so thank you. We saw the pictures earlier when Elizabeth presented, and thank you to that team. So I'm very happy today and very lucky to have some of our principal investigators from other countries, and we'll try and do our best to keep our time as requested. And so we do have a bit of a more complex title, which is RHCforFGC. And the key word really is respectful healthcare. And our presentations will all revolve around how do we how did we understand respectful, and what kind of research we carried out in a different way with different countries along the lines. So the partners, Canada, many provinces in Canada, including from east to west, at least, I'll give you a table in a minute, but at least over 20 researchers. France, and our colleagues from France were supposed to be here. They apologize, and there should be at least 2 or 3 of them online. So bonjour Armel, bonjour Fatoumata. Si jamais vous avez des questions, vous allez peut-être texter Birgitta et Sarah, et on va les transmettre pour vous. Also from Belgium, we have the pleasure of having the one who will be presenting today is Sarah O'Neill, and I believe I saw Sophie Alexander somewhere in the room. Please come forward and have a seat with us. We have enough chairs. I think I bumped with Sophie in the bathroom, and I wasn't sure it was her. It's unbelievable. We have been having meetings, but masks and Zoom, and so come on in the front, Sophie. And then we also have Sweden with Birgitta, Essén, and then we have collaborators in Switzerland with Jasmine Abdulkadir and Adriana Kaplan in Spain. So I will be very quick because we do have a number of activities that we have carried out, but you will be seeing them in more specifics with my colleagues who will be presenting. And we tried our best to give you the gist of it without any details, but there are a lot of them that are available in our publications. But in essence, we have done quite a bit of work together despite the pandemic, and we were able to meet at the very beginning in Belgium when we started to think out our project, and then just recently in Paris, where I was supposed to be in person, but everyone else was, and Birgitta and I were on Zoom, and I was there at 3 a.m. Sharp, which was 9 a.m. in Paris. So here are all the activities that we've done so far with everyone, and this is the ones from the specific provinces in Canada, and thank you, Susan, for sharing some of the snow, which we still have in minus 45 degrees Celsius last week. So it's very nice to be here under the sun. So we do have a number of partners who are also saying hello from Canada. A quick definition, given that we're talking about a very complex practice, and one of the guidelines that we used was a definition from WHO. Of course, quite a bit of controversy nowadays now in terms of that definition provided in 1997. We have encountered a number of partners who are not quite in agreement with this definition, but at least it helped a little bit to guide our work in terms of the procedures that involve partial or total removal of the external female genitalia or other injury to the female genital organs for non-medical reasons is the most important to remember. So in terms of KT, we did have a number of activities, starting from, of course, our research partnership. I need my glasses. presentation, workshop in presence in Zoom, scientific publications in Canada and various parts in countries of Europe. We've, of course, had a very challenging and currently our colleague Fabienne Richard from here, Brussels, who would have been here, but she's actually very much involved in the, this is the International Week of Zero Tolerance against FGMC, which started on Monday, February 6th, and they were all very involved at the Senate. Maybe Sarah can talk to us about it. And so we did have international undergraduate studies on various countries, funding opportunities, and a number of informative videos, because we had identified the fact that there were very limited videos for women themselves, a growing number of videos and teaching material for healthcare providers, but not so much for women themselves. And Sarah will be presenting the one that was done by our partners here in Belgium. So in terms of Canada, we have 5 objectives overall in our network, but instead of presenting to you in one slide, I will present to you one by one, and my colleagues will pick up. So one of the most important one was the Knowledge Attitude Practice Questionnaire, which hasn't happened in Canada, though for the past 4 years. Some were done, and we discussed for almost a year whether the Knowledge Attitude Practice Questionnaire should be the same for all the countries involved. After many conversations, we realized that our cultures were quite different for selected questions, especially when it comes to a very sensitive topic. So it ended up that France and Belgium did their work together, and we went with Switzerland and the US in terms of being a bit closer to the culture in asking questions, given that there is an extent to which we can ask questions that is more liberal here in Europe versus in North America. So we built our questionnaire in Canada based on the work done by a colleague in the US who worked at WHO and now is in the US, and in partnership with our colleague in Switzerland, and made our efforts to assess reliability and validity of various words using minding the fact that words matter when it comes to a sensitive topic. We also carried out a qualitative analysis in Canada, one of the first ones, so that we could gather in a better way the challenges for patients themselves and the clinician. And also recently, one of our partners, an MD from Calgary in Alberta, did also a very sort of what she called a quick, dirty assessment, though we had some very interesting studies and perceptions of their level of care they could give to women living with FGMC in Canada, given that the migration experiences are way different from the long history of Belgium, Sweden, and France. We also had in our objective 2 some review of online resources and training packages. We identified 161, but very few really that were accounting for sex and gender, though one of the interesting results is that between 1996 and 2010, there were fewer than 30 resources that we identified for Canada, for Canadian healthcare providers, whereas between 2011 and 2022, we had identified over 140 resources. So really building on the best practices in Europe, mostly from France, Sweden, Switzerland, and all the other countries. Other videos were also recently put together. I will not talk about the one from Belgium because Sarah will talk about it, but a number of them in French, I might add, that hardly exist to support healthcare providers, and that include women's voices. That was an extremely important element in our network, is to listen to women about what they needed, how they were viewed, how they were potentially objectified when they were discussing their conditions, when they were feeling in trust to talk about it. Takeaway observations from Canada, limited considerations of the perspective of women who have undergone FGMC. The majority of training packages refer to description of typologies, but nothing really accounting for women's voices. So a lot of classification, typologies, but we're working on including progressively women's voices. And another new launch that we just did last week is modeled on GAM's Access website, where resources can be accessed by women anywhere in Canada. And this is what's happening already for a number of years here in Belgium. And we use that example, that best practice in Canada, to then identify the organizations for women across Canada in terms of services in context of immigration, services for women and girls in context of gender-based violence. And we found over 700 organizations, but only 10 of them that were more or less addressing the needs for women affected with FGMC, but not directly. So we really need to work some more on that. And finally, we also had in our Objective 3 a review of estimates of prevalence, a question that still remains as to why should any country do an estimate of prevalence of FGMC in their country. We have identified 26 plus 1 ongoing right now in France, and we still did not have the clear understanding that apart from convincing to have more funding for more services for these women, we weren't sure that it really changed the condition and the lives of women. So in Canada, there is none yet, and we're still working on that and applying for a CIHR grant next month in doing that work for the first time in Canada. Our Objective 4 was to look at the legal aspect of FGMC in Canada, and we recently submitted a paper looking at how are the Canada's refugee appeal system involving FGMC actually addresses the request of women seeking asylum in Canada on the basis of the fear of having FGMC done in their home country. And we have identified the majority of them being Nigerian girls. So we have submitted that paper just to tell you that we have guidelines in Canada so that the commissioners, the decision makers are able to grant asylum, but yet the majority of them were not granted. And the majority of them, despite these guidelines existing, did not uptake those guidelines in their decisions. So finally, I will pass my mic to Sarah about the Belgium perspective. And I'll be back for the France, and then I'll pass the mic to Sweden. I think we take Sweden before, because you have a lot of time changed.
Thank you very much. So I'm going to talk about Belgium in particular. So I'm talking from a sex and gender perspective. Until kind of in the 1980s, it was often assumed that sex is biologically determined, whereas gender is socially constructed, whereas these things have changed a lot over the last, since Judith Butler. And I think the example particularly of kind of women undergoing female genital cutting, so kind of a change in the appearance of their sex, is a very interesting to look at, because in many places, these the social norms, so the ways in which women are perceived when they move from a country where their body is perceived as normal by everybody, members within the own family and within the own community, moving to a different health system where you've got healthcare professionals kind of taking care of a body that is not, doesn't fit within the social norms of how they were trained provide optimal care. So this is kind of why this is so incredibly important, that women, particularly given the increasing prevalence of women with FGMC in Europe and in Canada, of course, why it's so important to provide optimal and respectful healthcare, that these women feel, you know, at home very much, and especially given the fact that this very much affects their self-esteem and well-being. Some of the other presentations were also about self-esteem and well-being in this context. So what we did was we undertook a CUP study, as Bilkis has already said, which so with France and Belgium, it was easier to collaborate on this particular subject. So we ended up doing a kind of a CUP study on not just with healthcare professionals, but also with social care professionals, which we thought was incredibly interesting and important, because although we know that social workers are kind of at the front line of receiving migrants from FGMC practicing countries, looking after their, trying to make them integrate or be comfortable within our society, very, very little was known actually about their knowledge of the practice. Do they know, particularly like regarding prevalence or some of the other aspects? So that was something that we looked at in particular in Belgium and France. So what we found was that 39% of medical doctors, 81% of midwives, and 55% of non-medical professionals have already provided care for women with FGMC. So this is huge compared to what it was 10 or 15 years ago. It really shows that, you know, they are an important population that healthcare professionals have to provide optimal care for. And the other interesting finding for Belgium was that a large number of medical and social care professionals never bring up the practice during their consultations. And this is the case for medical doctors, up to 47%, 20% of midwives, and 26% of non-medical professionals. So we found this incredibly interesting. And then regarding kind of training needs, 75% of professionals stated that they would like further training on FGMC, which isn't surprising. But what exactly was it that they were interested in? It was more the relational aspects, kind of how to, particularly when a type of FGMC was newly identified, how to look after the prise en charge, like the way you take care of the woman within the system. What's the best way to go about it? How can you sensitively and respectfully care for women who've undergone the practice without kind of increasing the sense of stigma that they're already experiencing in a European context? So the other thing that they were very interested in was legal aspects on how to identify a child at risk and other things linked to prevention. So I just forgot to say at the beginning, so this was particularly a couple of CUP studies on this subject have already been done in Flanders, and now about 10 years later we did the first Francophone CUP in Brussels and Wallonia. In France the results are still under analysis, you know, we're still, the analysis hasn't been completed, so we haven't been able to actually combine the data yet, but that will be the fascinating next step. So I'm quickly going to talk about another tool that we developed. It was a de-infibulation video. So in particularly type 3 FGM, the woman needs to be opened up before childbirth. And this is a necessary procedure, obviously. It's recommended that this takes place in the second trimester. And many women, kind of young women who aren't married yet, it's often recommended that they become de-infibulated, but because of language difficulties, you know, these people speak many different languages and often there's not a translator available. So it has happened, we have had some reports of women being de-infibulated and having a sense of their virginity having been taken from them, or, you know, feeling their bodies being violated because of this de-infibulation, which they didn't understand. So in many places, like in Somalia and Sudan, infibulation is associated with virginity. So if a de-infibulation would be like a woman having her virginity, so which is, very complicated. So it's obviously incredibly important that they are well informed about what this what happens during de-infibulation, and the procedure needs to be explained to women properly. So we created this video based on focus group discussions that were done with women beforehand, and that was to identify the needs of women, and then each step of the video was validated by the women. So we've got this lovely video, which unfortunately we weren't able to show you today, and this is it from Belgium for now.
So you can stay, because it's mostly from France that we have.
The next, oh, okay, I didn't realize, okay.
Yeah, and it's going to be very quick. So
Just you've in principle got 2 minutes left.
Okay,
You still
so
have
it's
to listen to Sweden, but Bilkis, you're going to be on the panel, so
right.
maybe,
So I'll be quick. So this is just to recognize the contribution of our colleagues from France. And online we have Armel Andro and Fatoumata Silla, and also Claire Tanté, Marie Lesclingon, and Shamsa Lecoeur were all partners who contributed to this project. And unfortunately, they couldn't be here. Just to know that France is the pioneer country in the fight against FGMC, with a history of steady migrant flows. And so they do have best practices and did work for the longest time in trying to capture the complexities and to sort of address the large array of actions. And so they have done unique, so I don't talk about the CAP because already Sarah talked about it, and they're doing some amazing work already. But it is important to underline that France is innovating in terms of the famous estimates of prevalence, and it's mostly from indirect estimates given from international data, and then doing some indirect estimates with the local data, the local national data. So we need direct estimates, but those are impossible to gather, and yet they're doing some amazing work in France with an innovative protocol to look at a transnational basis with what they've done in Belgium and what they're doing down south in France. And what you can see is that the prevalence estimates vary between 0.7% to 7.2%. Of course, there is participation bias, and that we need to really look at the better estimates. Of course, we'll think about that when we do our work next year in terms of the estimates in Canada. So I won't say much about this one because Sarah already touched upon this. And basically in terms of what our colleagues in France wanted to highlight is there is unequal access to specialist social services, methodological biases that we have to address when it comes to CAP data collection, and limited institutional recognition, which is really important because we need to demonstrate that FGMC exists, and we need to be trained to identify so that we can give the best services possible. And more studies are needed, as they say, as usual. So now it is from Sweden.
Okay. I apologize
Thank you.
for this. Is it okay I take my presentation?
Of course, go ahead.
Merci beaucoup. So I come from Sweden, and I just going to give another picture about female genital cutting. Sweden was the first country in Europe who had a law already in the 80s. And Sweden has a very, very long tradition for gender equality. It's very, very mainstream since the 70s. However, I'm going to ask two questions. Okay, yeah, sorry. Okay, so I have two questions that I would like to discuss with you. And first of all, we are here to how was sex and gender addressed in reproductive health research? And I will turn it a little bit different. How is research results on sex and gender addressed in policy and practice? And I set up two hypotheses that FGM policy, it's very much inspired by activists and less to evidence-based results, research. The second is that practice is more inspired by increasing FGM court cases than present evidence-based medical certificates in court. This is a tough hypothesis, but let me give you 2 cases that is based on research we had done in Sweden. First of all, the dynamic of gender norms and culture, how it changed after migration, and is it reflected in policy in Sweden? The second is we went through medical certificate in court cases, the few court cases in Europe and United States that will show that there might be a misuse practice of the very important affidavit as a medical certificate. And let's go back to the country of origin where migrants come from. In Sweden, we have a huge group of Somalis, and they are all cut. And in the current society of Somalia, circumcision is gender equity, boys and girls. And women and men are by nature appropriate for certain tasks. That's the norm in the country of origin. Women shall have the main responsibility for children upbringing and so on. You know this. This is not a gender oppression according to the interpretation from a cultural relativist way. And right gender shall do the right things. Okay, what happened with the culture and the norms after migration to one of the very most gender mainstream country in the world, such as Sweden? We see that very, very, very quickly, the tradition of cutting girls is stopped. The practice, we cannot see any evidence in Sweden or in other parts of the Nordic countries that this tradition is upheld. However, the gender norms of boys are cut. And this is not reflected in the Swedish policies, such as the the Agency for Gender Equality. And another thing we see that norms are changing quickly, it's the parenthood. In Sweden, the Somali men, they're not allowed to be part of delivery, for example, in the hospital. They join the women during pregnancy, antenatal care, and delivery, and sharing also parenthood in a quite high percentage. The second thing I would like to just show you is that when we talk about the illegal cases, there is a scarcity of identifying illegal cases in Europe, and relatively few FGM criminal court cases have that we know. And this number is surprisingly small, given that hundreds of thousands of immigrants from FGM practicing countries are residing here in Europe. And there has been, from the European Commission and many governments, there has been a real call for identifying efforts to get more illegal cases. We want more illegal cases, you can say. So I have went through the court cases in Europe, and now I'm going to show some pictures that those who have not seen Genital and don't want to see genitals, you can just close your eyes. Okay? This is a girl who has been identified to be cut by one doctor, by one so-called expert, but to be uncut by another doctor. And this is in court. And you can see if you see any different or any cut or any damage of this genital. This is how evidence is used in court. And every time when there has been some suspicious cases, it gets an enormous publication in media all over the world. And this is from a study where we went through and see the difference of expert witness. And we asked the question, why do expert witnesses draw different conclusions in suspected cases of illegal cutting of girls' genitals? It's the same genitals. Dr. A does not see the clitoris, but Dr. B does. Dr. C identifies scars, but Dr. B sees physiological skin folds. Dr. D described normal anatomy, but at the same time conclude that it's most likely mutilation. Dr. E sees asymmetrical labia minora and just sees that cut labia, but Dr. B assesses it as part of normal variation of anatomy. This is presented in court and it gives confusion. So here's another genital that has been assessed differently. And remember that we try to, even if you're Black African, that you're innocent until the opposite is proven. So my message and the research that we are trying to get policymakers to understand is that we have to dare to see and handle facts with respect. Parents are accused, parents are sent to court, parents are in jail, and parents have lost custody, and all of them are migrants, and some of them are Black African or from religious minority groups. And I leave the question to you, what is the best interest of the child? To have parents in jail, innocently without evidence? I leave it like that. Thank you very much. This is some of the references from us in Sweden.